Hi, Dr. Windisch from Sparks Pediatric and Adolescent Medicine again. Welcome to our video series for parents. Please remember that these videos are not intended to replace visits to your physician. If you think your child is ill, please make an appointment and be seen. If we can be of assistance here and you'd like an appointment here, give us a call at area code 775-359-7111. We can get you in same day. But we cannot come to the phone to discuss the content of these videos. If you have questions, we need to see your child. Today, what we would like to talk about is spitting up in infants. Let me start by saying that all infants spit up. 100% of them do. So, per se, this is not an abnormal event and not necessarily something that needs medicine. So when do I worry? Now, when does a child need intervention? If a child is spitting up to the point where they cannot gain weight or they don't gain appropriate amounts of weight. If a child is spitting up and inhaling it, getting pneumonia. If a child is spitting up and it's triggering asthma. Or if a child is having tremendous pain with the spitting up. Those are all reasons, and arching and discomfort, those are all reasons to treat. So if you think your child has some of these in association with spitting up, by all means let your doctor know. If it's just painless spitting up, some kids are flat out volcanoes, and as long as they're growing, don't wear white shoes. They'll do fine. And carry a bottle of Stain Guard with you for a few months. Most children outgrow this by the time they're 6 to 12 months old. There are a handful who go on to be adults who have gastroesophageal reflux or acid reflux disease, but most do get better. What are some things you can do besides medicine? Well, the first thing is to keep the child elevated for 15 minutes after feeding, preferably head up or at the very least at about 30 degrees. Elevate the head of the bed to about 30 degrees as well. Frequent burpings while feeding your child, every ½ ounce to ounce of formula and every 5 minutes or so while on the breast, will help. If you are breastfeeding your child and your child's spitting up a ton and having some mild discomfort with it, look at things that might be in mom's diet that contribute to acid reflux. Caffeine, chocolate, alcohol, peppers, onions, tomatoes. Try eliminating those one at a time and see if we can find the trigger food, and if so, maybe you can eliminate some of the spitting up for your child. With formula-fed babies, we don't need to worry about that, but there are other issues with the formula, not necessarily related to reflux. If you can't control it with symptomatic stuff at home, then it might be time for medication, and there's really a whole host of medicines we use for children. We frequently will use a class of medication known as H2 blockers. The one that we use the most is Zantac or ranitidine. This is just like the over-the-counter Zantac HC for adults, except it comes in liquid for babies. Other H2 blockers that we might use include Pepcid and Axid, although those are a little less common to be used in infants. If that doesn't control it, we may add on medication to help the stomach empty, something called Reglan or metoclopramide. And the combination of Pepcid and metoclopramide, or ranitidine and metoclopramide, works a lot better than either one alone. So many times we wind up being on both of those medications. If that still doesn't work, sometimes we'll change the H2 blocker over to what's called a proton pump inhibitor. Proton pump inhibitors include Prilosec, over-the-counter, Prevacid, Nexium, the purple pill. Usually for children what we're using is Prevacid because there's been just the most testing and it's the easiest to give to infants. Nexium doesn't really have a good formulation for infants, and we don't have enough experience dosing infants with it, so I don't particularly recommend that one. Same thing with Protonix. Omeprazole or Prilosec, we used to use it at the time, came in a real funny suspension that was very difficult to work with. There are now better suspensions available, but they're very expensive and not so easy to get a hold of, so I find Prevacid's kind of the easiest to work with in terms of both price and availability for patients. If that's still not working, we may try changing the prokinetic, the medication that helps you empty your stomach out, from metoclopramide over to the antibiotic erythromycin. And you have to use erythromycin. You can't use its cousins, clarithromycin or azithromycin. That's Zithromax or Biaxin, because they don't work. But old-fashioned erythromycin is also a prokinetic, and sometimes that works a little bit better and even a little bit gentler than the metoclopramide. So there are patients who definitely respond to that. If none of the above works, then unfortunately we're looking at surgery. And the surgery has with it a whole host of complications that are really outside of the scope of this video. So we're not going to get into that here today. But there is a time and place for surgery as well, especially when the child is continuing to not gain weight. If your child is not gaining weight with the reflux, that's a very serious situation, because over the first year of life, your child's brain needs to double in weight. And if your child's not able to gain appropriate amounts of weight, his brain will not grow. Brain damage sets in quickly and is irreversible. So it's important to get a handle on this right away and be aggressive in our management early on if that is being a problem. Close follow-up with your physician during this time, if failure to thrive is an issue, is critical for your child, because we need to ensure that there's weight gain. Sometimes that spitting up can be severe enough that it can damage the lining of the esophagus and even permanently scar it. And if there's a lot of pain that's left untreated, the children can become what's known as orally defensive. They won't let you put anything in their mouth because they know that if they eat, they have pain and they don't like it. That can be irreversible, or take years to reverse. So again, getting control of this quickly and aggressively if need be. In addition to all of that, there is a time and place for thickening the feeds from the child. So sometimes we'll have parents add a tablespoon of rice cereal per ounce of formula. Please talk to your physician before you do this. I know this sounds like something that's great to do, and maybe I should have mentioned, people think we should have mentioned that earlier when you were talking about positioning the baby. Why didn't you? And the answer is because I don't want children receiving rice cereal in their formula without talking to the physician. This really is a prescription with the same amount of risks and same amount of side effects of the other medications that we've already mentioned. So I think that really needs to be under physician's guidance only. It does need to be a full tablespoon though, less than a measured tablespoon. And that's a level tablespoon, not a eating spoon, not approximately. It needs to be measured, 1 tablespoon per ounce. And then it needs to be dissolved well into the formula. Will often help with the problem, and it also increases the caloric intake for the child. With this, you might need to stretch the nipples of the bottle or use a larger flow nipple because the feedings become rather gummy. That's okay. But again, only do this under the guidance of your physician and with close follow-up with your physician. This is not the kind of thing to do on your own at home. Positioning, keeping the baby upright, frequent burpings, elevating the head of the bed. You can do all of those before you talk to your physician. Don't thicken the feeds without talking to your physician. That's a recipe for disaster. I hope this has helped to eliminate some of your concerns and to give you some ideas about some of the various treatments that we use for this very common event. Realize that most of the time the children outgrow this on their own. We just need to help them over this hurdle. What we'll often do, or at least that way I handle it, is if I have to put the kids on medicine, put them on high-dose medicine, and we wait till they outgrow their dose. As they outgrow the dose, if the symptoms come back, we bump the dose back up. And again, wait till they outgrow the dose. Usually we wind up bumping the dose up once or twice, and by the third time they've outgrown the dose, they've outgrown the symptoms. There are a handful of kids that need the medicine longer. We can't guess who they are early on. There's no good diagnostic criteria for this. People want the test for reflux. There really isn't any. You can do barium swallows, but those can overdiagnose or underdiagnose reflux. They are of value though. They make sure there's no strictures in the esophagus. They make sure there's no webs in the intestines. They make sure that there's no tumors blocking the outlet of the stomach. So at some point in time that may be worth doing. There's something called a pH probe, where a probe is stuck down the mouth or the nose of the baby and left in place for 24 hours while the patient is then sent home to eat. Those are of value, but interpretation of that data is very difficult and can really only be done by a good pediatric gastroenterologist. And realistically, there's only a handful of centers in this country where that's being done with any reproducible values. Now, if you happen to be near one of those diagnostic centers, Children's Hospital of Los Angeles, UCLA, Kaiser Sunset, just to name 3 huge ones in Los Angeles, then that's wonderful. But for most of the country, that's not something that's really available to the patients and just not doable. And plain x-rays aren't going to help. So we're kind of limited based off of history and physical here. This is old-fashioned medicine. I hope this has helped to enlighten you on this very common and very frustrating event for children, and I hope this eliminates some of your concerns. Again, if you'd like us to see your child here to evaluate for this, give us a call at 775-359-7111. We do need to see you to be able to help you, though. We'll talk to you next time.